Welcome to the heart failure management. So heart failure, we can manage it in the clinic as an outpatient and as an inpatient setting. Okay, so let's discuss the outpatient first. So first off, what are the symptoms of heart failure?
Shortness of breath.
Okay, so first we have left heart failure, we have left-sided heart failure, and we have right side heart failure. Okay, so if we discuss, let's do it here, symptoms, signs and symptoms. So if it's left side or could be right side, what are the symptoms if it's left side heart failure?
If it is a left side heart failure, we will have symptoms. We have fluid in our lungs, so shortness of breath will be the first symptom.
Excellent. So you have dyspnea and paroxysmal nocturnal dyspnea, like wake up in the middle of the night,
We
breathless.
will have orthopnea.
Orthopnea. Okay, perfect. Okay, that's the thing. What are the signs that we can find? We have crackles, the signs. We have curly beeline
on the X-ray.
We can find effusion
on the X-ray.
On the X-ray. Perfect. How about right side heart failure? What do you see in right side heart failure?
In the symptoms, we will see pedal swelling,
leg swelling, okay.
extremity swelling.
Extremity swelling. What else?
We will.
Where do you see the JVD?
That will be a sign, right?
Okay, yeah, that will be a sign.
So in the sign, we will see raised JVD.
What else? Could be abdominal swelling too.
Yes.
Okay, so this is the...
We can see hepatomegaly as well.
Yeah, hepatomegaly on physical exam. Okay, weight gain, that's a very important sign. Weight gain. Weight is very important in management heart failure. So you gotta see, even if patient readmitted, you look at their previous admission, what was their discharge weight, and then your goal is to lower their discharge weight. Like for example, if they discharge at 160 pounds, now they're 180, so you make sure you gotta make them drop 20 pounds. So these are the things. So what are the pathophysiology of heart failure? Basically, the failure of the ability of the heart fails to do its function. What that causes the kidney to be pissed. Okay, so what are the, if we want to do it as a pathophysiology, so the problem is that the kidney will be pissed. So what is it going to do, the kidney, if it's going to be pissed kidney?
So if I will start,
it's going to release what enzyme?
If the kidneys are not getting the enough blood, it's going to release erythropoietin first.
No, erythropoietin is going to take longer. That's going to renin. That's the most important one. And then renin gonna bring the angiotensin. Okay, and the angiotensin too, what does that do? That's the enemy of the heart. So what is it going to do?
It's a potent vasoconstrictor.
Increase the afterload. Support going to increase afterload because it's vasoconstricting. And what is it going to do? Also, it's going to retain more fluid, so increase preload too.
Because it's going to stimulate aldosterone.
Yeah, stimulate aldosterone due to aldosterone.
And then you will retain more fluids.
Aldosterone effect. So this is the thing. So now this is what's worsening his condition. So the body mechanism is worsening him. So what are we gonna do regarding management? So it's make logical sense to just work on this process, okay, or work on heart contractility. So heart failure, we have stages. We have NIHA classification, okay. And the management is going to be different based on the classification. We have class 1, which what we call it asymptomatic. How do you manage that if it's asymptomatic? Let's bring that here. Asymptomatic. What do you give the patient if they're asymptomatic?
We will give the patient
Beta blocker.
Beta blocker.
Excellent. This is we start in beta blocker. Okay. This is class 1. Okay. And we can do what?
ACE inhibitors.
AC inhibitors.
Or ARBs.
Okay. Or ARBs. Excellent. So this is the asymptomatic. They have like heart failure. Okay. But just shortening. Even they have mild shortness of breath, but mild symptoms. Okay. So this is the AC inhibitor, basically just inhibit the angiotensin, so decrease the burden on the heart. So that's what we do. Now, what if number 2, class 2, symptoms with exertion? What do you add to it?
We, apart from the above 2 drugs, we can add diuretic.
Yep. We can add diuretics. Okay.
And we can also add spironolactone.
So spironolactone, that's going to be stage 3. Like if we do stage 3, an activity of daily living. So this is when you consider the spironolactone. Okay. Or we can do something is called bidilators. What does that mean by dilators?
That means it dilates arterioles and venules both.
Yeah, which means the hydralazine plus isosorbid dinitrate. Okay, so this is if it's so now it's asymptomatic beta blocker, ACE inhibitor or ARB. If it's exertion, diuretic, we can do that, furosemide. If it's activity of daily living, spironolactone, bidilator. And then what if it's for at rest?
Then we will increase the contractility of the heart.
How do you do that?
We give
dopamine,
inotropic drugs.
excellent, dopamine, okay. Or you can even add milrinone, okay. Or if these didn't work, then we can consider what is it? Left ventricular the assisted device. We can do device, or we can do even transplant, heart transplant. So this is for stage 4 heart failure. Okay. Now, what are the things that we manage? What are the diagnostic criteria that we want to do? What are the things that we want to consider?
For the diagnosis, we need to have echo done on the patient first.
Okay. First, BNP. Let's start with labs. Okay. So let's go here. So let's add it on a different thing. Let's add it here. Okay. We have the diagnosis. We do the BNP. If it's less than 100, no heart failure. What if it's BNP more than 500? Then this is CHF, okay? Heart failure. Let's make it no CHF. Okay? So this is for the diagnosis. Okay? And what else we do? We do echo. Echo, that's a good thing. Echo. Usually reduced ejection fraction.
That's in systolic dysfunction.
Yeah, in systolic dysfunction. But if the diastolic dysfunction, usually have hypertension. Diastolic due to hypertension usually. So So when diet, this is important thing too. Let's add it to the classification. Let's add a diet. What are the diet for heart failure? What do you want to give them?
We want the patient to be on heart healthy diet, like
Less
less
than-
salt,
Less than 2 gram of NaCl salt a day.
less
What
1
else?
liter of water per day.
Less than 2 liters of water per day. And what are the other things that we want to consider regarding diet? Weight. We check the weight daily. Okay. Check weight daily. And avoid non-steroidal anti-inflammatory drugs. Avoid NSAIDs. Okay. That's the thing. Yeah, we gotta consider. Okay. Okay, so that's basically summary of management of heart failure in the clinic, outpatient. But in the inpatient is gonna be different because the people who get in the inpatient, usually their symptoms, in addition to all of these symptoms that we mentioned in the outpatient heart failure, which is dyspnea, paroxysmal nocturnal dyspnea, orthopnea, crackles, Kerley line diffusion, they have additional symptoms, which include in the history. What else? What do you find? What do you think you're gonna find? Fatigue. What else?
Tiredness,
Mm-hmm.
sleepiness.
Somnolence. Okay. What else? Altered mental status. And what do you see on physical exam usually?
That depends upon which sided heart failure it is.
No. Okay. Let's see. You can even have pulses, alternan. This is going to be interesting because of the effusion, and you will see narrow pulse pressure. Okay, and you have wrist and ankle edema, like it's the generalized edema. Okay, edema, like okay, everywhere. So this is basically the additional symptoms. So it's something serious. Okay. And generally, usually heart failure, 70% of them, 70% of heart failure, 70% is what we call wet, which means a lot of preload, and warm, which means a lot of systemic vascular resistance. That's what it means. Okay. 20% is cardiogenic shock. Okay, which means acute decompensated heart failure. Usually wet, a lot of preload, but cold. Cold means there's no systemic vascular resistance. There's no systemic vascular resistance and wet, a lot of preload. So this is pretty dangerous. And we have another one, which is 10% of heart failure, which is dry and cold, which means there is not much preload and there is no systemic vascular resistance. It's called low flow heart failure. So let's focus on the first two because these are the most common one. So what are the steps of management of an inpatient? So it's going to be interesting. Treatment, what is it going to be? Number one, we're going to start with what?
Diuretics.
Diuretics. So that's the difference. Okay? That's the diuretics, which could be oral, could be IV. Okay, we can do that. What are the second thing we can do?
We can go for the vasodilation.
Okay, we can do vasodilations, like we can do IV enalapril. Okay, or we can do IV hydralazine. Okay. What are the third option?
We can go with inotropic drugs.
Okay, inotropic drug, like what, like which one?
Dobutamine.
Butamine, yeah, especially in cardiogenic shock. And we can do Milrinone. Okay, there's one thing, never ever beta blockers because it's decompensated. So whenever ever do
In acute heart failure.
in acute heart failure, let me add that. Good addition. Acute heart failure.
Because it decreases the contractility of the heart.
Excellent. Due to decreasing heart contractility, because usually in the inpatient, usually something is severely decompensated. That's why we do these things. Okay, and you gotta check out the jugular venous pressure. The higher the jugular venous pressure, the worse the condition. So that's basically heart failure management. Is just to do a quick summary of the situation. Signs and symptoms: dyspnea or dyspnea, paroxysmal nocturnal dyspnea, crackles, Carlibby line, fusion, left, leg swelling, abdominal swelling, weight gain, that's right. In the outpatient setting, we base on the management. If it's asymptomatic, just having maybe signs or tiredness or some mild heart failure, beta blocker, ACE inhibitor, or ARB. If there's shortness of breath with exertion, you add diuretics. If there's affect daily living, you add spironolactone, or you can do bidilators, hydralazine plus isosorbate dinitrate. If it's at rest, you do dopamine, and last resort, transplant or device or transplant. And you advise them to have less salt, less than 2 grams of salt, less than 2 liters of water, and check weight daily and avoid insults. That's if it's an outpatient management. What if it was an inpatient management? Then we gotta do first diuretics. The second thing is that vasodilators, hydralazine, nalpa. Third one, inotrope, dopamine, marijuana, and make sure we avoid beta blockers. And in a summary, that's the management of heart failure. Thank you so much for listening.